Yeah, thank you very much for the invitation. And I agree, this is a really important topic. So we'll be going through a little bit about what the obstacles are to integrating palliative care into general cirrhosis management, and really appealing to you as to why we need to find strategies. Sorry, I just want to put this at the bottom there, why we need to find some strategies for getting around these obstacles. And I want to start with a video just to sort of set the stage for, I think why many of us went into medicine, and also what are getting inside the minds of our patients a little bit. And this to me really brings out why palliative care is so important. Oh, sorry. And so that video is all about empathy. And I think that's such a crucial component that we all try and do very well, but we need to remember how much our patients have concerns and worries about their condition. So with that as a background, let's start with the first misconception that I think is the big one. And that's really a misunderstanding of what palliative care actually is. And we often understand palliative care as meaning providing a good death. And so it is definitely about end of life and those last few days of life, avoiding distress and suffering. But it's become and evolved into much more than that. And indeed, the World Health Organization defines palliative care as improving the quality of life of patients across their life-threatening illness. And I would say for cirrhotic patients, that obviously starts from diagnosis. And so it's not only just looking at their liver and even their physical suffering, but also looking at their psychosocial and spiritual suffering. And as was mentioned, there is this concept that they're either curative or they're palliative. And this came up for me during one of our transplant rounds when I suggested we need to start integrating palliative care into every patient's journey. And the surgeons, one of the surgeons pointed out that no, palliative care is only applicable for people who are in the last few days of life or who are delisted for transplant. So that misconception is very, very common. And instead of this, I would like us to think of it like this, that palliative principles, and we'll talk about these, are sort of happening and need to be acknowledged alongside curative therapy. So just because someone's on the transplant list doesn't mean that they're suffering. Obviously, physical, emotional goes away. Those are still issues that we need to consider and deal with. I think the other major misconception around this is that palliative care means consulting a specialist. And this would be wonderful if there's enough specialists around to be able to see all of our patients. But unfortunately, at least in North America, there are not. And so I think we all need to get better at integrating what I'm going to call these palliative principles into our practices. And so these palliative principles, or practicing with a palliative approach to care, it's all about support. And again, it's things that you're doing every day. But looking at it a little more concretely, this is main concepts of advanced care planning, which we'll talk about in the next slide, symptom prevention and management, and then really looking at a needs assessment, not only for the patient as far as functional status, but also for the caregivers who are taking on a real burden of care, looking after our patients, often without being paid for it. And at the bottom here, it's effective communication skills. And we'll talk about that too, which I think is an essential component of palliative care, but also of medicine practice. So advanced care planning is a big one. And this is called different things, different places, but essentially it's sitting down with your patient and knowing who they are. And this can happen over a series of visits to find out what their own personal journey has been, what their goals and their values and beliefs are, and how that frames how they think about and talk about what their wishes are for end of life. And that leads to something usually on paper that's a medical order called a goals of care designation. And again, it may be called something different everywhere. And it also is a very important part of it is to sort of designate a surrogate decision maker. So someone who can speak for you if you can't speak for yourself. The second, I think, misconception is that we have an unclear understanding of why this is all important. Why do we need to care about this? So in part, I've mentioned to you already, but our patients really have a tremendous symptom burden. And this was some data that we've just looked at. There are many quality of life studies out there showing that the mean quality of life scores in these patients are low. Out of 100, they're getting 50s, 60s, even when they're child Pu A. They have a lot of worries. And you can imagine a lot of financial distress for many of them. And the transplant list just adds a whole nother bucket of worries for them, not being sure if they're going to get transplanted, really just having that carrot dangled in front of them as their only hope. And so that is somewhat unfair to do to patients without adequately supporting them. If we look at the symptom burden, there's very many ways to do that. One of the scales was developed in Edmonton, actually the Edmonton Symptom Assessment Scale. And if you do this on patients, you will be shocked to see how many of them score high on all of these indices. And so if this was a couple of studies that I've highlighted, but in 50 patients where they did this ESAS, even with a mean MELD of 15, 85% were scoring with moderate to severe symptoms. And out of a big study that Sherry Rogel did, almost 1,300 patients, 25% were on painkillers or opioids, but still a third of them had pain, 45% of them, more than 6 out of 10. And that sort of brings up the concept of learning a little bit more about these symptoms in general and recognizing that obviously a lot of them are not just physical, right? There is definite psychosocial contributors to many of these symptoms, including pain, that often need further exploration. Integrating early palliative care works. And so this, sorry, it's a bit blurry. This was a nice study by Bauman et al., where they actually integrated early palliative care referral, and they found a significant improvement in some symptoms, including itching, appetite, and depression. So, doing this can help our symptoms, our patients' symptoms. We also know that palliative care across the board helps caregivers. It reduces patient anxiety. It reduces bereavement anxiety. So after the patient has died, it improves quality of life. It reduces costs of care and reduces the number of times they come back into hospital. And in some studies, it's actually reduced mortality as well to do this. If we don't do it, it definitely leads to inappropriate care. And even particularly among our patients, even listed for transplant, surprisingly, they have lower rates of advanced care planning than non-listed patients. And this is probably that misconception around curative versus palliative being in separate boxes. Patients delisted for transplant, so those are who are really too unwell, many of them still get aggressive care and suboptimal symptom management. And so this is data from two studies, one from our site and one from my colleague Jennifer Lai's site. In our study, this was patients who were delisted. 28% of them only had had these advanced care planning discussions. Despite being delisted, almost half still went to the ICU after delisting, and almost 20% were put on dialysis after delisting. So I would say that some of those things are potentially too aggressive as far as management. In California, what they found was that 17% of their patients were actually referred for palliative care consultation, but the majority of them were within the 3 days before death. And the majority of them were so that they could transition to what's called comfort care or hospice, very minimally related to symptom management. So again, things happening quite late. And in line with that, this hospice referral, or place where people go usually for their last 6 months of life, even mean hospice stay for cirrhosis patients that were referred was 29 days versus 60 days for others. So again, things are happening too late and not enough of this. Having these early discussions with your patients in the clinic is really important, because we know when people get admitted to hospital, up to 80% of them, even in the non-cirrhosis population, are unable to participate close to end of life in the decision-making process. And that, you can imagine, might be an even bigger issue with our cirrhotic patients with hepatic encephalopathy. And although we would like to think that our family and friends know what we want, studies have been done to show that if you have a surrogate, or if you don't have a surrogate, rather a non-informed surrogate, they guess patient preferences for CPR only modestly better than chance. And only a third of them actually correctly identify treatments that the patient's willing to accept. And so this is not only applicable to our patients, but also to us, to have somebody who really knows what our wishes are in the case that we weren't able to speak for ourselves. If you have an informed surrogate, and I think that's one of the biggest take-home messages from this, to really make sure that each patient has a surrogate decision maker, they really work with the team. They can't know everything that's going to happen, but they know the patient and they know their values. And so they can work with the team to make the best possible decisions. Third misconception I want to cover is that, and this often comes up, is that patients don't want to discuss their disease, and that it'll cause loss of hope. So we don't want to talk about death or outcomes. And this is very far from the truth, actually, for the majority of patients. And so this was some work that we did looking at just surveys in 100 of our cirrhotic patients. Many of them were actually still early stage in their disease. I'll focus on the last two questions. One, the second question about how important it is to know the truth about your health, even though it's not good news. You can see extremely or very important in the majority of people. And then when we explained to them what advanced care planning was and having these discussions about the natural history of their disease, when did they want these discussions? They wanted them in clinic. They didn't want them at hospital. And I think one of the biggest things there is that they don't want to have the discussion with a person that they don't share a connectedness with. This is just a couple of quotes, but the bottom line from our patients was, you know me as a patient, I want to have this discussion with you. I don't want to have this discussion with someone that I don't necessarily know when I'm in hospital, when I'm very sick. So that was the overwhelming response when we did interviews with our patients. And there are so many studies to show that advanced care planning does not affect hope or anxiety. Okay, it in fact reduces anxiety for both the patient and for the caregivers. Fourth misconception is really that there's uncertainty about which patients need palliative care. And I would say that my bias is that everyone from the beginning of diagnosis needs some aspect of this, discussing the natural history, at least, for example. And this is important because we don't know, unlike frailty, which is a slow decline, or advanced cancer, which is this, oftentimes patients just get, they're okay, and then they come to a time when they're very, very sick and they deteriorate quickly. With cirrhosis, like they have these dips in function that can happen very acutely, and they can come out of it or not come out of it, and sometimes it can be quite unpredictable. So again, it's very important to have these discussions early because we don't know when these dips are going to happen. These are some triggers that have been suggested in the literature, and I think we would all agree with these, that this is sort of decompensated cirrhosis, anyone awaiting liver transplantation, or anyone who's been delisted for transplant. But again, some of these principles I would favor even moving further ahead in the cirrhosis journey. And I think this is also a big one. This is the second last one. So many non-palliative care specialists feel ill-equipped. And so as a hepatologist, I didn't get trained in palliative care. How am I supposed to be able to do these things? And I think this is not uncommon. And this is probably why things like advanced care planning discussions, where we're trying to actually get to know about the patient and their values and their preferences, the literature would suggest that the majority of these do happen in hospital, and the mean time for this is 1 minute. And that's clearly not adequate to do a proper job of really figuring out who the patient is and who their surrogate is, etc. We're quite comfortable discussing things like diagnoses and treatments and procedures, but we're less prepared to discuss things around that are softer, like around dying and comfort. And also, it's really tough to prognosticate in these patients. It can be challenging. There's many things that need to be considered. And so when it's difficult, we often tend to give vague information, or we have a tendency to overestimate outcomes or say, oh, you'll be okay. It'll be okay. So those sort of tendencies, I think we need to recognize in ourselves. I think we can do a better job with learning how to speak to our patients so that they understand. I did have one more video, which I will show. I'll save 5 minutes for questions at least, but we want to be able to discuss real scenarios so that our patients can actually not just have percentages, but they can really imagine outcomes that would be unacceptable to them. So this is called the best case, worst case scenario, and I think it's so valuable. It was developed for making decisions around surgeries, but it can be used for any sort of event. And this is I think it's a 2-minute video that I'll show. But this the case is a gentleman who has Clostridium difficile that's very severe, and the family is deciding between whether it's a surgical option for that or whether it's not. So I'm just going to show that next.
Surgical problem is bad news. Patients and families need to understand that this event is unlikely to end well and could potentially result in his death. Even if he does survive, it's improbable he will be just as he was before. How can you be sure Mr. Lombardi's family understands his condition is grave? It is essential to clearly announce that he is very ill. You might say something like, "I have some bad news. Your dad has a life-threatening problem. It is going to change his life. I worry he's going to die, even with surgery. I want to make sure you understand the options." Next, introduce the best case, worst case framework. Let's look at the graphic aid. To begin, identify which options you will present. In Mr. Lombardi's case, you're presenting 2 options: total colectomy and a non-surgical option, comfort care. For each option, draw a box and a star connected by a vertical line. The box represents the worst case outcome associated with a given treatment, and the star represents the best case outcome. Somewhere along this line lies the most likely outcome. Most likely may be close to or the same as the best case or worst case, or it could be somewhere in between. The idea is for you to combine your knowledge of the patient's overall health with your understanding of the current problem to give patients and families your best estimate of what is likely to happen. Telling a story is key. This helps patients imagine an unfamiliar experience so they can prepare and make decisions based on what is important to them. While surgeons often focus on providing precise risk calculation, these numbers don't help patients envision what it is actually like to have surgery. So, how can you explain the risks and benefits? By translating the statistics you know into stories. Instead of talking about a 20% risk of renal failure and a 35% risk of stroke, tell a story about what a patient's life might actually look like if these complications occurred. You show the probability of these events by where you position the most likely outcome on the line between best and worst. Pull out key elements from your story and write them on the graphic aid. During a busy day, this seems time-consuming, but it is critical. Patients and families will refer back to this graphic aid in order to deliberate about options after you have left. Let's get back to Mr. Lombardi. If you operate on him and everything goes really well, in your best case scenario, what would his recovery be like? Would he be able to go home again? Tell the story. If everything goes well, he will have a big operation to remove his colon, and his stool will come out in a bag. Afterwards, he will be critically ill in the ICU for a number of days. He will need a breathing machine, and he won't be able to talk. In the best case scenario, we would remove the breathing tube a few days after surgery, and he'd stay in the hospital for another week or so before going to a nursing home, where he'll have to work hard to regain his strength. If his luck continues, he may even be able to go home again, but he will be weaker, have a bag for his stool, and need a lot more help.
And then they go through the worst case, but this is online on YouTube. You can just Google best case, worst case. It's about a 10-minute video and it's excellent. So again, just improving communication skills, having some languaging around common questions, like raising this, I want to share with you my understanding of where things are at with your illness. Is this okay? Oops, sorry. Or how you would choose a surrogate decision maker. So if you were too sick to speak for yourself, is there somebody who can make medical decisions for you? And so I think that these things are very important to just have in our toolkit. And I'm going to skip just to the end, to the take-home points. So I think bottom line is that the majority of patients want more information about their health and their prognosis, and almost all of them have these unaddressed fears that they're dealing with. And the meaning of palliative care, if that is the main thing that you get across today in this talk, I think that's essential, that it's often misunderstood. So taking this concept of palliative principles, and it's not just end of life. And we must all work together, I think, to overcome these barriers and to understand the importance of this in our patients' journeys. And I'll end there.
Great. Excellent, Dr. Puneeta. If I may, because all the topics are all different, we perhaps should take the questions at the end of the talks. So if I can start, obviously you covered a lot of things, and a lot of the things as non-palliative clinician, we feel very uncomfortable approaching. And one of the things which you highlighted as point 3 is about, if you mention palliative care, you're taking away hope. That is a kind of, unfortunately, that is the kind of concept. How do you get around the problem? Is the problem with the clinicians or is it with the patients?
Yeah, I mean, if we look at the literature, the problem is probably a bit with the clinicians, in that patients, when you talk to them about this and when you do these discussions, they actually do want honest communication. It really depends upon, I think, taking the time to have those discussions and to answer their questions, and not assuming sort of more paternalistically that we're going to take away their hope, right? Because having them have the ability to actually plan realistically for the future, whether it be a best case scenario, worst case scenario, that's why I love that description, because you can give them both options and sort of say, it could be anywhere in here, you know, but let's prepare for the worst and plan for the best, is what I always try and say to them.
Okay, anybody else has got a question?
Hi, Puneeta. This is Sonal. How are you?
Hey, Sonal, I'm great. How are you?
Yeah, thanks very much. That was a lovely talk. That was fantastic. I mean, as it happens, we're in the process of setting up a palliative care unit at Aster CMI Hospital, and we've been working with our oncology colleagues because of some of your insights that a lot of the patients that we get will not necessarily come from an oncology background. They will come from a liver background as well. So this was a very useful framework to work with. I mean, Matthew's point is pretty valid. You know, we have at least in India, there is a cultural block that we face, that a lot of relatives tend to tell us to not talk to the patient directly because they want to protect the. I mean, there's a sense of trying to protect their loved ones from bad news. And I know that it's a little different in Canada because people do want to take ownership of their problems and their diagnosis. So, I mean, in your own experience, do you find a cultural difference in between people coming from, say, an immigrant Indian background versus, a Canadian background?
Yeah, so no, I think there's definitely that for sure. And that needs to be acknowledged. And I think all of this needs to be sort of culturally adapted. But at the same time, that's why maybe that best case, worst case scenario is still a good one to look at, because you can still sort of give people an idea of what the best case is. So you're not necessarily just saying that this is the way it's going to be, you're going to die in this amount of time. We don't know. We're not God. I mean, there definitely is a spectrum for everybody, and everybody's bringing in their own other comorbidities and personal life experiences that will influence how they cope with their illness. So I think it's all individualized. Asking permission is important, and assessing readiness for people to hear about, are they ready to hear about prognostication? So that's certainly one part of what palliative care specialists would normally do. And then taking it from there. So if they are very ambivalent, and yet their prognosis is deteriorating, and you need to be able to make some decisions, for example, ICU or no ICU, et cetera, then we need to have strategies to start to bring up those situations. Like, what if this were to happen? What would you want? So not necessarily being blunt about the prognostic prognosis, but at least starting to open the conversation, because it's often a bit of fear, isn't it, that is causing that challenge with having that open communication. Fear on the patient side, and fear on our side for saying something wrong or not being right on what the prognosis is. So it's a skill set, and what I've found works best is to actually work with the palliative care specialists and really observe how they do it, because they are magical at this. They're excellent. So even just watching what they do, and I've spent a lot of time with my colleagues on that. They do this wonderfully, like without impacting the patient's hope.